I think there are a variety of reasons for that. It just came out in 2011. And it takes some time for the uptake, for people to kind of get used to it and get familiar with it and kind of develop a comfort level. So that's one thing. And the second is that we learn very quickly that the side effects are very high, much higher than what the registration trials report, because registration trials patients are generally healthier and much more motivated and monitor in much more rigorous protocols than what we would do routinely. So those combinations kind of discourage many providers, or at least did not really encourage many people to jump on it. I think it's a two ways kind of things, because patients get a lot of information on the internet and patient support groups, but a lot of the time they get the information from the providers too. So if the provider is not encouraged enough, then it's unlikely that they would encourage the patients. I believe so, and nowadays we have much better tolerated regimen even today, and in the next 6 to 12 months we should get on oral therapy, so the side effect profiles should get much better, and efforts for education for both patients excuse me, and providers will certainly help, and the press and the lay press as well as the medical press have been doing a good job. Many patients know about it and have started to come in already. There are two things that are important in this, is that hepatitis C is quite overlooked in Asian patients. Hepatitis B is much more common, so it gets much more attention, correctly so. But hepatitis C is also a significant disease burden in some Asian subgroups, not all Asians, but Southeast Asian, for example. The prevalence can be 3% to 6%, much higher than the US general population prevalence. And the other thing that is important is that Southeast Asian patients have a high prevalence of genotype 6, and the treatment response is different. So genotype 6 patients fortunately respond much better. In our meta-analysis that we just presented in a lecture presentation today, the SVR, the pool SVR was 80%. So that's quite good with the own regimen, PEG, interferon and ribavirin. And even in genotype 1 patient, the pool SVR was about 60%, much higher than the SVR in genotype 1 Western patients. So it kind of has an impact on the future direction, because here we have access to samipavir, sofosbuvir, and likely many more better drugs in the very near future here. But in those resource-limited areas, it's unlikely that they will get these medications right away, and the cost may be prohibitive even in the foreseeable futures, even at reduced costs. So it is encouraging to see that SVR, even for the quote-unquote own stuff, PEG, ribavirin, is quite good, 80%. In separate studies, we found the anemia rate is usually higher in Asian patients, but despite maybe a higher requirement for dose reduction of ribavirin, we still saw a much higher SVR, 80% in genotype 6 and about 60% in genotype 1. I would like to encourage every providers to screen their patients for hepatitis C, because I think that's the first barrier. Patients don't get treated if they are not even diagnosed, and that should be for all patients. And in the US, we have the new CDC recommendations that the birth cohort 1945 to 65 should all be screened. And I also would like to remind providers with Asian patients coming from high endemic areas to also screen those patients, even without the absence of the usual risk factors. And especially their treatment response is very high, even with the old regimens.